Welcome, everyone. We're so happy that you were able to join us today. A couple of housekeeping things. We are recording. This will be posted afterwards on our website for viewing after the webinar. Please, if you do have any questions during the talk, please enter them into the Q&A, and they will be answered at the end of the talk around 11:40 or 12:45-ish. And with that, I will pass it over to Dr. Hamid Gambari to introduce Dr. Figueroa, our speaker.
Thank you so much, Ashley. And this today is a real treat to have my colleague and friend, Dr. Alberto Figueroa, who is a graduate, one of the original graduates of the Aikens Innovation Academy. He is the Edward B. Diethrich Professor of Surgery and Biomedical Engineering. Dr. Alberto joined University of Michigan in 2014, and he's co-founded a company that he originally worked on with us at the Aikens Innovation Academy. His current academic work is focused on computational methods to model blood flow algorithms to describe stress-mediated growth and dynamic flow regulation of blood vessels, and computational methods to assess stability of thoracic and abdominal endographs, as well as hemodynamic performance of cardiovascular medical devices. He's also an instructor to the undergraduate courses at the BME and has got multiple NIH large grants. And as I mentioned, he is the associate director of the Aikens Innovation program, and a colleague that I have a pleasure working with all the time. So with that, welcome, Alberto, and we love to hear your journey.
Good afternoon, everybody. Thank you so much, Hamid and Ashley, for the great introduction and a very generous introduction, and for the opportunity of speaking today. I'm going to introduce my colleague and friend, Dr. Brahmaji Nalamothu. He's actually going to help me with the presentation. So let me pull up the slides first. Yeah, I think without any further ado, Ashley, can you confirm that the slides can be seen?
I cannot see the slides quite yet. There might be a delay.
Okay, so let me share my screen. 1 second.
Yes, I can see your slides now in PowerPoint, not in full screen.
Okay, that should be it now.
Perfect. Yep.
Okay, so yeah, so I'm sure we can use the time. So it's such a pleasure to tell us about our story. And again, this is going to be a joint presentation between Dr. Nalamothu and myself. He's going to take over the first, 20% of the presentation or so. This is a long title, so I'm not going to read it, but hopefully you will get the picture that this is a story of innovation that started here in 2 different labs at the University of Michigan, and it has to do with diagnosis of coronary artery disease and microvascular dysfunction using images. So the name of the company that we will be referring to a few times during the presentation is Angiography. And so now, Brahmaji, the floor is yours.
Thanks, Alberto. And thanks, Ashley and Hamid, for this opportunity. Alberto, you can go to the next slide. I think I'm going to walk you through a bit of how we got to where we're at this moment in time. It's been a very interesting experience for myself. I've been in academics for, over 20 years now. This is the first company that I've been involved with, and it's been really an incredible learning experience. Just to give you this sense of timeline, actually, even before 2018, I met Keyvan Najarian, who is a faculty member here at the medical school in the Department of Computational Medicine and Biology. He might be known by many of you. Keyvan and I met at an MCirc, which is now the Weil Institute mixer, where they were trying to bring together clinicians and methodologists. It's kind of a common set of stories. A cardiologist and a computational medicine expert walked into a bar, literally, and then we sat and we talked. And I was explaining to him some of the problems that I see clinically. And Kayvon was at that point in time thinking a lot about, some similar issues in a different part of kind of the human body system. This led to us thinking a lot about how computational tools, particularly computer vision tools and AI, might be able to help with the analysis of coronary angiograms, which we'll get into a little bit later what those are. I will say that the initial focus of this was on anatomy, which was a big concern at the time, but it just really shows how many times things can pivot over a period, a relatively short period. Um, very soon after we had met and then we decided to found this company, we were able to kind of connect with Alberto. Actually, Kayvon was the introduction to Alberto. And Alberto, as you'll know, is an expert in computational fluid dynamics, so flow. So we had been focused initially on anatomy, and then we started to understand maybe the importance of physiology. And we were able to, working with the three of us, start to get some extramural funding around this. We were able to get an American Heart Association award. We were also able to get some initial funding at kind of small increments. And then in 2022, we were even able to get a STTR award. Alberto was the PI on that grant too. Up until this point in time, I'll just tell you, this is the way that I've thought of this framework. We were really focused a lot on the idea of invention. We were all professors here at the University of Michigan. We were very interested in discovery, and that's a very important part of the process. But I have to say, in 2023, we had a foundational change. The best way I can describe it is we went from the idea or mindset of invention to the mindset of innovation. Like, what are the discoveries we're making that can be brought to the market? What are the products? What are the tools that we can perhaps develop that would be of greater interest? So even though we had had a company for all those years, I think our mindset was kind of born of that kind of academic framing. And a lot of that I have to credit to Mark Summers, who is the chairman of our board. Mark is a pretty remarkable individual. He's a University of Michigan graduate. He's gone on to be a serial entrepreneur. He's exited a couple of companies in the past, and he's been really, in many ways, kind of the inspiration and spirit behind our company. I think that Mark helped us really understand the framing of what innovation means and the value of bringing a product to market, to users. He was able to quickly assemble and help us assemble a team that includes Scott Berger, who's our CEO, Vas Parachuri, who's our CTO. And then we've gone on to, increase the company. We've included like experts like Gabrielle Seska, who's our regulatory affairs expert. And now we've gone on to really move forward. And I'll be, just really excited to let you know that even going to the point where we've had 2 FDA meetings about a pre-submissions, as well as a meeting at TCT, which is the large interventional cardiology meeting, just a couple of weeks ago, where we started to decide and make decisions about a clinical trial, which we are hoping to move forward next year. Next slide, please. So the basis for this is really around kind of many of the patents and data sets and data use agreements that we've been able to create here in partnership with the University of Michigan. We at this point have 4 issued patents. We have 9 pending. We have several data sets licensed to AngioInsight as well. And then finally, we have this novel solutions, a secure enclave services, which is under partnership with AngioInsight. And I'm going to ask Alberto to just say a few moments, like spend a couple of words on that, because I think that's been a really unique part of this partnership as well.
Yeah, so this is an example of how many branches an innovation project may take, right? So the research computing office here on campus offers this service of putting together secure enclaves. And one of the things you can do with this virtual machines environment that includes CPUs and GPUs is to engage with external entities to either work together or on an innovation project, or in some even cases, to have them access our data at Michigan Medicine without ever leaving our premises and do some sort of annotation work or tasks that are very important for machine learning. So I found this purely from a university standpoint, such an example of us actually moving rather on the forefront of what it takes to make these tools move forward through engagement with entities that sometimes are outside the university.
Thanks, Alberto. All right, so a quick crash course on cardiology. Next slide. So what's the problem that I'm actually trying to talk about and describe that this tool addresses? Well, coronary artery disease is the disease that affects like the large branches of the heart's blood vessels. The heart pumps blood all over the body, but the first branches that come off of the aorta actually feed back into the heart because the heart is a muscle like any other muscle that needs oxygen and nutrients. So it's very important that those blood vessels, contribute blood flow. Now, what can happen is that those blood vessels can develop plaque, and when that builds up, we call that a stenosis. You can see that in the little cutout diagram there, and that can limit blood flow and cause ischemia or a lack of oxygen, which can lead to tissue death. And then people come in with all sorts of symptoms around that. Now, what I described was the big blood vessels, but what we do know is that these big blood vessels actually, branch off and off and off and off until they get into very small microvascular vessels as well. And it turns out what happens in the big blood vessels can also influence what happens in the small vessels as well. And then this can lead to coronary microvascular disease. And although there are some unique risk factors associated with coronary microvascular disease, again, disease of the small vessels, there's also a lot of overlap with some of the conditions we think about, whether it's high blood pressure, diabetes, high cholesterol, smoking. Women in particular seem to be at a higher risk for CMD, which comes into our project a little bit later. So if you think about coronary artery disease and then coronary microvascular disease, CAD and CMD, it's just a very common set of problems. It's very expensive, and it can lead to a lot of challenges for patients. Next slide. This is just a diagram that kind of gives you different patterns of disease that might be able to occur in a patient. If you look in the upper left corner, this is, I think, the typical type of thing that we oftentimes think about. Big branch vessels that are, diseased. Alberto is like kind of, showing some of the stenosis that's out there. But then noticing that there's actually disease in the microvasculature as well. So both CAD and CMD. If you go to the upper right, it's CAD in isolation. If you go to the lower left, it's actually just CMD in isolation. And then if you go to the lower right, it's kind of diffuse disease. There's not like one single stenosis or blockage, but kind of disease up and down the blood vessel. And all of these have different manifestations. Next slide. So when we think about diagnosis, there has been, decades worth of work on how to diagnose CAD in particular. More recently, there's been a focus on CMD too. And I'll talk a little bit about this, but I'm going to focus mostly on CAD at the moment because the way that we look for it is we actually have started to look for anatomic blockages. So we actually look for stenoses, and we can either directly see that through a CT examination or a cardiac catheterization. Sometimes we can actually measure the implications of that blockage by stressing a heart and then seeing how that heart reacts, either through an EKG or through some other type of imaging like an echocardiogram. That gives us a functional assessment of whether or not that blockage is important. And then finally, I'll just tell you in that lower right corner is an assessment called FFR, which probably in the last decade and a half has like shifted the paradigm of cardiology. As I had mentioned in the beginning, my initial concern and problem was that, could we figure out a way to better diagnose and define anatomy? But what it turns out is that we've started to discover that the physiology of a blockage matters more. The same blockage severity, a 50% blockage, might have different implications based on flow characteristics. And that's kind of when we brought Alberto into the picture as well. And what had initially happened was this idea of, can we get computer vision tools to just help me see the blockage better? To now suddenly saying, can we get computer vision tools to help me measure flow across the epicardial stenosis for CAD assessments? So mimicking what's happening with that lower right corner there, the invasive assessment of an FFR, which is simply a pressure wire that goes across the blockage and measures what the pressure gradient is in that area. Next slide. All right, so if you go to the next slide, I'm going to tell you a little bit about what exists with the market right now and what we had envisioned, and you can see how the product has actually even shifted over time. So initially, the way that people used to use these computer vision tools was through a simple tool called QCA, which applies to an image edge detection software, and it can kind of delineate the vessel and then the degree of blockage. It's kind of a semi-automatic contouring of the angiogram, if you think of it. And again, this was our goal: was can we replicate this? Can we make this process a little bit easier? What we started to realize was, again, functional analysis was actually the key, and how could we actually shift towards that? So the next slide. So as I had mentioned, we were trying to mimic different types of patterns across this, and I'm going to just explain to you a little bit, because what I had talked to you about was FFR, which evaluates the epicardial stenosis, but we do know that flow matters across the entire system, both the epicardial and the microvasculature. And these three brackets define that. You can keep going ahead, Alberto. If you think about the entire flow across both the epicardial, the big blood vessels, and the microvasculature, that's CFR, which stands for coronary flow reserve. It's the ratio of flow if there were absolutely the highest amount of flow possible in a coronary vessel, versus the resting flow. And typically in most people, because you're resting, you're limited in the amount of coronary flow needed. And then when you do have to exert yourself, you can increase that flow up 2.5, 3.5, 4 times what that resting flow is. In diseased vessels, whether that disease happens in the epicardial or in the microvasculature, that CFR is going to be diminished. FFR, which is the bracket to the upper left there, actually suggests that that's the pressure gradient across just the epicardial, the big blood vessel blockage, and that's stenosis severity. And there's a whole host of literature now that supports that FFR can help guide stenting, because it can tell the physiologic significance of that one stenosis. And it's actually better than anatomically just looking at the stenosis severity. And then finally, there's a recently described metric called the Index of Microcirculatory Resistance. This is a unitless measure that essentially gives us an assessment of what the resistance is in the microvasculature bed. Most of the resistance in the whole coronary system is in that microvasculature bed. And this is something that can be calculated using a wire-based method, which is what Alberto's going over there. So in the cath lab, if you have a problem, you can actually place a wire down that and not only be able to measure that FFR, but be able to measure the IMR and the CFR as well. Next slide. So there have been some growth in this area. In the space of FFR assessment, there have now been many tools that are starting to come online that have focused on whether either using CT images or angiograms, the ability to quantify FFR without placing a wire down there. We can talk more in the Q&A session about the different strengths and weaknesses of these different tools. But these tools are out there. A couple of them are FDA approved. Some of them, including CathWorks, are making their way into different cardiac catheterization labs, even ones down the street that are starting to use this tool. So instead of placing a wire down there, just with the angiogram images themselves, you can quantify an FFR assessment. Next slide. Now, CMD has not had anything that can assess it computationally, at least widespread at this point in time. But CMD is becoming a very hot area in cardiology. There's increasing recognition that we've been focusing so much on the epicardial vessel, largely because we have therapies like coronary stents and coronary artery bypass grafting. But recently, there's been interest both on the med device side and the biopharma side on new therapies that could potentially be used to treat microvascular disease. And this has raised a lot of interest in better diagnostic tools for diagnosing CMD. Next slide. So to summarize, the computational methods for CMD assessment are lacking. And what we have at this moment for coronary microvascular disease is largely limited to some types of nuclear medicine testing, cardiac PET. We have like one of the world's experts here at Michigan in Venkmurthy who does this, and we do a lot of these types of testing. But this test is not widespread. It's not widely available across lots of institutions. We're lucky here, but it's not commonly used. And then we have this Coraventus CoraFlow system that I had described before, which is a wire-based system that can give you the CFR, the FFR, and the IMR. And I think I'm going to send this over to the next slide. I think I'm going to hand this over to Alberto at this point, but the core problem, if I could summarize it, is if we could get one single tool that could computationally understand these important physiologic and anatomic assessments without necessarily putting a coronary wire down the vessel. So Alberto, I'll hand it over to you.
Thank you, Brahmaji, for wonderful overview of the history and also the clinical problem. So I'm going to now describe a bit, general culture, broad concepts of coronary angiography, which is the imaging modality that we used. So here on the bottom right, you see a coronary angiogram. In this coronary angiogram, the way it works is you have a catheter that flashes a contrast agent, and that allows you to visualize the vessels and the flow of that contrast agent down the vessels in real time. In this picture on the upper right, maybe you can see this yellow tube that represents the catheter. You basically park it either on the left side of the circulation, of the coronary circulation to your right, or vice versa. And then this looping video shows you that only when you inject the contrast agent do you get to see the vessels moving and the contrast itself washing down the circulation, right? So this is the data that we use. This is the way on the upper left the system looks like. So this is a dual C-arm, so biplanar system that is capable of getting two of these videos simultaneously, meaning registering time. It's not done very often, but it can. And this is the data that we have. It is actually a very common interventional procedure. There's 4 million cases of coronary angiography assessments done in the US and in Europe alone, probably about 10 million in the world at least. And this is kind of the schematic of a system taking these videos simultaneously at the same time from two different views. It's rather high resolution images, especially if you compare to standard CT. And the real power of these, which is how we got interested in using this modality for our AI and computational analysis, is its time resolved nature. The frame rate, tentative frame rate, is 10 to 15 frames per second, could be more, could be less. Okay. Historically, though, this imaging modality has been really underutilized as far as extracting information, the kind of information you can get from these images. For the most part, even today, cardiologists would look at the videos, they will make a visual assessment, so that QCA methodology that we showed you a few minutes ago is not even that commonly done. And it's for the most part an eyeballing proposition here, right? Of course, cardiologists are very smart, and they understood from the beginning that understanding the patterns of the washout of this contrast agent gives you a lot of meaningful information about the system that you are trying to understand. So they came up with subjective indices, for example, the so-called TIMI, which stands for thrombolysis and myocardial infarction. And they have a grading system, which is, very crude if you want. So at TIMI 0, it means that you don't even see the contrast agent making it all the way to the distal total circulation, indicating a complete occlusion. And on the other hand, at TIMI-3, where the contrast agent washes down super rapidly, it indicates normal perfusion and likely a healthy coronary microcirculation. These indices are, of course, they don't really give you a quantitative metric that you can use in order to stratify patients for diagnostic purposes. There's slightly more sophisticated methods that kind of try to put more of a number to it. This is the TIMI frame, but in the interest of time, I'll just keep going for now. So before we get into the details of what we have done here in our labs, I'll have a summary slide that gives you the pros and cons, because like Brahmaji explained, this is a very active field, not just in academia, but plenty of companies that are trying to use image-based diagnosis of both large vessel disease and now, for cases like ours, microvascular disease. So you have the CT as an imaging modality of choice, or the angiograms as an imaging modality of choice. And this slide gives you the pros and cons of each approach. Like everything else in life, there's advantages and disadvantages to each choice, right? So the standard resolution of standard CTAs, computed tomography angiograms, is about 0.6 to 1 millimeter cube compared to a significantly better resolution for the angiograms. The big advantage, of course, of CT is that it's three-dimensional. You deal with three-dimensional information from the get-go. And this is the big disadvantage of angiography. You deal with 2D. And actually, I didn't explain this before, but you do take multiple videos, more than two, typically 3 or 4, for each side of the heart. And necessarily, those videos are not going to be synchronized. So this is actually very complex signal that you need to work with, okay? The fact that they are two-dimensional, and in general, they are not synchronized. The flip side is, of course, CT, you have a static representation. You get nearly no insight into the physics, none. You have a good description of the images, but no real visualization of flow of any kind. And this is where angiography as a methodology shines. You don't have a probe that self-reports velocity, that's true, but you can probably imagine how through the use of computer vision and machine learning, you can extract a lot of functional information from this signal, and that will be the bulk of my presentation. The last thing I would say, and this is more for the business side, if you think about the workflow of clinical care, patients that get a CT ordered, they are nowhere near the cath lab. They usually go to, an outpatient clinic. They get some sort of radiology CT study, and therefore you don't have a pressing need for real-time solutions. This is, in fact, what happens with companies such as HeartFlow. You have hours to do the analysis, and that's fine. But if you want to pursue an approach that relies on angiography as your imaging of choice, the patient is on the table. So absolutely the need for real-time solutions, therefore make it almost inevitable that you have to adopt an AI, machine learning, deep learning approach, right? So this is a big differentiator between these two modalities. So hopefully this introduction was helpful to understand, to frame the problem for those of you without necessarily a cardiology background. And now we've done a lot of work. I want to make sure that we have enough time for Q&A. So I'll just give you a flavor of the different things we've worked on, but I'll be happy to entertain questions, okay? So apologies if I just rush through some of these things, okay? So once again, our data source is coronary angiography, right? We have several videos. Each of these static images really represents several videos for one side, whether the right or the left. And since Brahmaji and I started working together, we have done a number of tools which reflected into patents and products ultimately licensed to AngioInsight for anatomical and functional assessment, right? So this is just a summary of some of them. And I'll give a few words about some of them. So these include segmentation, stenosis characterization, 3D reconstruction, flow extraction, and then some of these quantification of these indices, such as FFR and microvascular resistance. So again, I'm going to browse through these very rapidly. The very first thing we did was to develop neural networks for segmentation. So we developed a network called AngioNet. In this field of AI, things move so rapidly that this was published 2-3 years ago now. With the advent of tools such as Meta or other segmentation tools, you can do so much better than that, right? But the needless to say that the process starts by the need of identifying where the vessels are automatically with an algorithm that is basically near real time. And this is what these images show. A real big issue here, and this goes back to the limitations of angiography data being two-dimensional, is the three-dimensional reconstruction part. This is where we have spent a lot of energy, and now the company is also developing such groundbreaking approaches to deal with this. So I'll just try to illustrate. I'm not going to get into the weeds. But so you have basically two ways of doing this. When you have a series of two-dimensional views from an object, you can, in this case, naively try to do a projective geometry approach where basically you try to map where corresponding points of the object are located in 3D space if you know the position of the source of the X-ray for each of the two C-arms of your system, right? So this is an approach that in principle will work. The problem is how much noise, if you want to use that terminology, in the data we have. We have a beating heart. We have videos and images that are not synchronous in time. And we actually are imaging a complex object where sometime, or oftentimes, I would say, many of the vessels overlap with each other. So it's really difficult to tell which vessel is closer to the observer and which vessel is farther away from the observer. So this is like a fascinating problem, really, because of the technical challenges that I'm trying to describe here. And we have done basically a number of different approaches, and it's very much ongoing work, both in the company and in the lab. One approach that I'm going to briefly summarize here it relies on the realization that, okay, doing this with projective geometry where there's so much noise, it might be difficult. So can we train machine learning algorithms to do this? So this is basically the approach. And what I'm going to briefly show you here is that we developed a very proof of concept methodology where relying on information from CT scans for patients for which we also have the angiograms, we develop a methodology that allows us to have exact correspondence between vessels in three-dimensional space that we can generate from the collection of CTs that we use to create this vessel generator, and then their projection into standard clinical views. That is what the angiograms will entail. So this paradigm, having the exact precise correspondence between what you get in the clinic, which is these two-dimensional views, and what you ultimately are seeking to obtain, which is the three-dimensional reconstruction, we have a way of producing these, at least using synthetic data that relies on this limited data set, right? So again, without getting into a lot of detail, we have used this initial approach that relies on machine learning, that we have a way of training using synthetic data, and this is kind of this publication that you have here and some preliminary results. Collaborating with Professor J.J. Park, who is a computer vision expert in the computer science department, we are taking more a deep learning approach to this problem. Okay, and in this deep learning approach, the idea relies on basically using vast amounts of data. We estimated that we have close to 10 million coronary angiograms in Michigan medicine, individual images. And so the idea is to use, it's a very different approach, really, deep learning rather than machine learning, to reconstruct the position of these vessels, but actually over time as well. So this is very exciting ongoing work that Liam Wang, which is a very brilliant computer science student, is helping us with. So yeah, this is really just before I move on to the physical part. You know, the flip side of the coin, if you want, what is making our life challenging, dealing with data that is intrinsically two-dimensional and has all these complexities to it, but it makes for really fun efforts that we're doing both here and in the company. So in the last 10 minutes that I have, I'm going to shift gears and I'm going to tell you more about what I think is one of the bigger value propositions of the company, really, and even scientifically, which is using these tools to not just characterize the anatomy or the geometry, but to really get insights into microvascular dysfunction. Okay? So this is really kind of what occupies a huge chunk of our work at the moment. So, and here's the proof of concept. So if you understand this slide, you're going to understand our approach to the problem. So on the upper left, you have a coronary angiogram showing the process that we have seen before, right? How the contrast agent is injected and how it travels and washes out. Using some of the machine learning tools that we developed, you can apply a frame-by-frame segmentation to that angiogram that would give you a quantitative characterization of where the contrast agent and how much contrast agent you have on a frame-by-frame basis. So hopefully you can see how the video on the left produces the video on the right. From the video on the right, then it's straightforward to produce a histogram of contrast agent intensity, how many pixels show contrast agent versus time or versus frame on the video. So what this thing shows is, okay, at the beginning for the first 10 frames, there's no contrast. Then we inject it, we have a rapid increase. And then this, in this case, is a normalized histogram. We reach a maximum, and then this histogram decays as the contrast washes out. So our idea is, by examining features and characteristics of these histograms, is it possible to develop data-driven models that will give you insight into microcirculatory parameters, such as the index of microcirculation resistance or the flow reserve that we discussed before? So let me show you an example that made us realize that this was possible. So here you have two videos. Again, the raw video, two patients, I should say, patient blue and patient orange. So in the top, you have patient blue, the raw angiogram, and the recursive segmentation. And same thing for the bottom patient. When you plot the histograms, you see how different they are. So you see that for the patient blue, there is a very rapid increase of the amount of contrast agent, but most importantly, a very rapid decrease. In comparison, when you look at the orange patient, you see that the decay of the contrast washout, that slope is much shallower. I should say that these two patients, none of them has large vessel disease. If you look closely at the videos, you will see that there's no stenosis. So naturally, it is reasonable to expect that the differences in contrast washout dynamics are going to be dictated by whatever happens in the microcirculation. And there are clear differences between these two patients, right? So naively, or maybe not so naively, you would expect that the orange patient has a harder trouble evacuating the contrast agent, indicating perhaps a higher microvascular resistance. So we went on to examining many of these curves in many patients. So this is a cohort of over 100 STEMI patients. And especially if you look at the right-hand side, you see that the slope of contrast washout is tremendously different. And this made us think that perhaps it's a very sensitive signal. So what we do in the lab is, okay, let's first demonstrate with a first principles model that is indeed the case. So what you see here is a CFD model of contrast injection. So in this case, we are representing the vessels the main vessels of the right side of the coronary circulation. This is the root of the aorta, and you also have a catheter that will be injecting the contrast agent. What's really important about this model is not just what you can see here in the center, but these electrical circuits that we are actually coupling to the outlets of each of the coronary branches that the model has. What these electrical circuits do is they represent the microcirculation. High resistors, low resistors, higher compliance, lower compliance, they're going to give you unique insights onto the microcirculation for that territory of the heart and as a whole for the entire patient. Okay, these are fairly established models in biofluids, but yeah, this is what we do. We are able to calibrate this model to reproduce patient-specific hemodynamic waveforms, cardiac output, pressure, waveforms that have the patterns of what you observe in the heart. And basically, this is the solution that we obtained. With a model like this, we are able to represent synthetic angiography. So in the upper panel, you have velocity, pressure, and most importantly, injection of the contrast agent. Once you have the injection of the contrast agent computationally, you are able to produce these computational angiograms with similar views as the ones we use in the clinic. And then you are able to create those histograms that I told you about 2 slides ago. The difference now is that we have complete correspondence between microcirculatory parameters that we use to create this simulation and features of this curve. So we have a first principle model that allow us to connect and correlate and study conditions of the microcirculation with properties of these curves. So we are in business now, once again, to do machine learning training. One thing we did is just to confirm that this is indeed the case. In that model, in that electrical model, we considered cases where we increased the value of those resistances. So we consider a baseline case, which is what I showed you before, and then moderate and severe disease cases where we simply increase those resistances of the microcirculation. We didn't change anything else about the model. The injection was the same, cardiac output was the same. And what that model shows you, indeed, is exactly what the clinical angiograms show you. That when you go from the healthy baseline patient to the moderate disease and severe disease, you see that the slope of the washout becomes shallower and shallower, therefore validating the first principle and the insightful nature of this model to do machine learning training. So this is what we have done. We have also shown that we are able to calibrate the model to any real patient angiogram. So this is a case of calibration under baseline conditions for a patient. In the bottom, you have the actual angiograms. And in the top, you have our simulated angiograms. And you see the 2 washout curves, simulated and real. And same thing for hyperemia. Okay, so the model is meaningful and the model can be calibrated to match any patients. So with this, and through a very bright postdoc who I believe is listening right now, we developed deep learning models that rely on the CFD model of contrast injection to estimate indices of microvascular disease. And, you know, this is kind of some high-level picture of these indices. So we develop a model for IMR, Index of Microvascular Resistance, and we develop another model for flow reserve. And, you know, so far we have only done synthetic training at the university. The company is, of course, taking these ideas and having a much more direct approach towards developing a product, if you want, going back to the point raised by Brahmaji at the beginning, the difference between invention and innovation, right? So the company really is taking these ideas and with different approaches, kind of trying to estimate the right thing. So I'm going to give it back to Brahmaji, but this is kind of, I apologize for how much I packed on the technical side, but hopefully it gives you a flavor of so many opportunities that combining tools around imaging, machine learning, and computational modeling has to make a difference in how we are able to diagnose diseases that before would rely on invasive assessment, and now we can use basically these non-invasive approaches. So I'm going to turn it over to Brahmaji to just close the presentation.
Great. Thanks, Alberto. And as I had alluded to in the very beginning, just over the last few months or so, we've been able to really align with a number of clinical experts around the country around a study that we're hoping to launch next year called the Smart Flow Study. This is a study that we've worked with our regulatory partners with at the FDA. It will include approximately about 600 or so patients, and leading centers around the country will be involved. The co-PIs will be Dr. Todd Vilnius at the University of Virginia and Dr. Carlos Collette at the Cardiovascular Research Foundation. Yeah, no, we're totally excited. I'm just going to end with just, as I've been reflecting on this and discussing this project with Alberto, it's been a long time since 2018, since that moment when Kayvon and I decided to kind of start this up, and then soon afterwards brought Alberto on board. And I've just been really excited about a lot of the energy around this. To see something in your own research work move towards kind of a product, and to be able to even imagine that one day these types of tools will be available to providers in the cath lab is just very exciting. I think that it's just such a great example of, again, going from basic discovery all the way to a usable product and commercialization. And so it's been wonderful to have all the support of a number of groups here at the University of Michigan, and just very grateful, for this ecosystem that Hamid, we've really started to create here. So with that, I think Alberto and I are open for questions.
It looks like we have one in the chat. A question from David Gordon. How much of the microvascular resistance is due to fixed disease versus vasospastic physical constriction, which may be amenable to pharmacological intervention? And can this technology allow for such vasodilatory testing in the cath lab?
That's more up your alley, Brahmaji.
Yeah, no, it's a great question by Dr. Gordon. More recently, people have been trying to endotype the different types of coronary microvascular disease. So as I had alluded to earlier, CFR and IMR are both measured. Sometimes there are individuals who will have an abnormal CFR and a normal IMR, or vice versa. So they'll have like um, conflicting values. When they both line up and you have a low CFR and a high IMR, it makes sense. And folks know that those individuals seem to have the worst prognosis. When you do have like conflicting assessments, there's a thought about whether or not this is due to a component of fixed disease. So for example, fixed disease is thought to exist if you have an IMR that's elevated, but the CFR can respond to it. The ones where the CFR is felt to be abnormal, but the IMR is normal, people believe that that is a limitation of some of the vasodilatory capacity of the microvasculature. I think we're just starting in this stage about trying to understand like what each of these different types of endotypes mean. I think that there is a lot of pharmaceutical interest in this. To be honest, no one's really figured out a way to target the specific microvasculature. So most of the pharmacy right now, and there have been a couple of clinical trials, have been trying to ideally suit the types of anti-anginals we use these days, whether or not it's beta blockers, calcium channel blockers, nitrates towards kind of angina. And there are some studies that have shown that if you do have evidence of microvascular disease and you use a stepped approach clinically, that you might be able to improve angina symptoms versus not having this information. But I think a lot of that is just in evolution at this point. I'm not sure if our study and the technology currently, as we're evaluating it, will be able to like step into the spaces of these different types of endotypes. Um, one of the things that I think we'll have during this clinical trial, we're trying to do just some of the basics of matching some of the measures that are out there clinically, but I think we'll have an incredible amount of information. In particular, I think once we have this information and the contrast intensity profiles that Alberto had alluded to, I think there's a lot of hope that we might be able to determine from some of those signals, maybe the specific endotype differences across patients.
Yeah, that was wonderful, Alberto and Brahmaji. I wanted to maybe ask you a question about the journey, and if you get a do you don't get do-overs in life, but if you did get a do-over, can you speak a little bit about things that you wish you had done differently as you were kind of going through this journey, and things that you would recommend people think about as they embark on this?
Alberto, do you want to start?
I'm sure there are many.
Yeah. Yes. Yes. Um, Man, I mean, it's yeah, we could be talking about this for like an hour, but I think just to keep it high level. But first of all, let me tell you, maybe this sounds too philosophical, but I do think that in this project, at least, things have happened for a reason. um, you know, you can clearly tell that, the stage in which stuff was being developed here in the lab was obviously a very different approach to the problem, more research, even though we did have the company, of course, but it was more at the research level, trying to ask very fundamental questions, and which is basically what I covered today here. The company has its own IP portfolio, and they are obviously driven by the need of getting into market fast, right? So to me, it has been really interesting to see how the approach to the same problem fundamentally differs between what you do in a laboratory setting within a research university, and then how a company needs to do things, right? When a company encounters a new problem in the lab, it can easily take a year to say, okay, let's think about these. Let's the company usually goes about it and finds a solution within weeks, a month at most. So it's been really interesting to see that. So of course, I wish we would have done things faster, right? And what enabled us to do so, like Brahmaji indicated at the beginning, was really getting in touch with people who had the ability of making a tremendous difference, right? So in this case, Mark Summers, our chairman, was so instrumental in helping us. Someone with the experience of actually holding our hands and taking us through the process of pitching to investors, getting money, getting you connected with people who have done it before, and can guide you, identify not just the right people to work at the company, but also investors that could help you. And then that basically is what accelerates, that brings the spark, and takes you to an entirely different dimension. So that would be my short answer. But like I said, the longer we spend here at the university, it also allows us to understand the problem more deeply, and to be in a position that when this opportunity presented itself, we could recognize at a very primal level that was going to be a big catalyst. Brahmaji.
Yeah, no, I think it's a great question, Hamid. I don't know if there's something that I can think of specifically about doing it differently. Part of it's that it's a lived experience, and it's hard to understand how I could have done it differently, at least my own contribution to this. I'd say the lessons that I learned are one, this is something that I've heard a lot of entrepreneurs talk about, but be flexible, right? Like I initially thought, okay, I just want this to help me read angiograms better. And what it's focusing in on right now and what the value add 7 years later is on this really narrow space of microvascular disease, which is becoming increasingly recognized and increasingly important. If we just built something that helped me read angiograms better, that really wouldn't bring a lot of value to the market, right? So understanding and being flexible on what the eventual kind of value you're bringing is really interesting, and that only came through, I think, conversation and just a lot of back and forth. And there's so many people that were involved in kind of shifting the focus of the company in that direction. Um, I think the second thing I'd say is so outside that flexibility is just luck plays a lot of it, right? We alluded to like not just Mark Summers. It was very lucky that we were able to get Mark Summers to be involved with the company, but some of the folks that he's been able to bring in and the talent that we've been able to get on the company side, it's been incredible. And I think that that's a real big part of the experience that I've kind of found. Um, and then I'd say the last thing is just like a real deep appreciation for how hard this is, right? Like every single time I see a product now, like that I even use or others use in the cath lab, I'm like, man, it took a long time, right, to get this all the way to the finish line. And I appreciate this so much more now, having gone through this, and all the deep expertise. I had mentioned Gabrielle Zeska. I've been able to, watch her work with the FDA, and just the deep expertise she has in those conversations has been really just amazing to see. And this is coming from someone who, I mean, I spent my career 20 years like looking at clinical research and clinical studies, but that lens and trying to figure out how do we frame this so that we can think about the approval and the required data needed. It's just a different way of kind of understanding the problem. So I've really started to appreciate that more too.
Ashley, I noticed there's 3 additional questions. Is that okay if I answer them?
Yes, please do. Thank you.
So the first question is, given that the model learns vessel flow characteristics from angiography, do you see potential for adapting this approach beyond coronary vessels, for example, to renal or peripheral? And what would be the main barriers to that translation? So absolutely, great question. We part of vascular surgery, so we have a big interest in applying these tools for diagnosis of peripheral artery disease. As these Meshari knows probably, it's also renal angiography, cerebral. So they each have different things about them. In typically for these other regions, you only take one view. But there's no motion. But in the renal, there's significant motion. But so each area has its own kind of intricacies. But I think you can share many of the ideas. So great question. And then the second question is: do you assume a single microvascular wing Kessel applies to the heart? We actually have regional values, so each branch will have its own, and we can customize it. But yeah, great question. And then a comment from Mark, which is very nice. Thank you, Brahmaji and Alberto, for a great presentation and for your very kind comments. Thank you, Mark, for taking the time to be here as well, and for your ongoing support through the years.
Well, I just want to say thank you so much for spending the time with us. It was a very enlightening conversation, and really thoroughly enjoyed the presentation. I particularly like the clinical and the research back and forth on it. I think it was super helpful and insightful. If you have any questions, please reach out to Brahmaji and Alberto. And thanks again for spending the lunchtime with us. Look forward to seeing you soon. Thank you.
Thank you.
Thank you.